Pleasure to be here. Thank you for your time. Maybe we'll switch gears just a little bit and talk about healthcare system modeling. Unfortunately, my co-presenter, Dr. Jenny Bazran, was unable to be here due to some last-minute changes in the needs of her schedule. So I'll do my best to present in her absence. But she's with the Saskatchewan Health Authority, and we've been working together quite closely for the last few years. The Saskatchewan Health Authority is the health authority in the province of Saskatchewan in Canada, which is the main administrative organization that manages the healthcare system across the province. So 1.2 million people, and 5 major hospitals, and dozens of other smaller ones. And I want to talk about the concept of the digital twin and how it may or may not apply within the healthcare space. So I think many of us are familiar with the term digital twin. I just wanted to get this kind of out of the way. There's a number of different kind of working definitions for a digital twin, but many of them focus on this relationship between essentially a physical system of some kind and then some virtual system, with the idea that the relationship is very close, something of a, as I showed on the previous slide, something that mirrors, is some sort of replica, or fully describes. And I think this is a really powerful framework to be able to imagine a virtual environment where you can be doing a lot of your potentially expensive interventions and do them in the virtual space where it's cheaper and safer than it is in the physical space. But I think it's important to highlight that the concept of a digital twin is much more common and certainly came out of the space of manufacturing. This is some people did a review of the publications and literature, and most of the publications in the last few years have been in the manufacturing space. And if we look at this one here, healthcare is way at the bottom. So, and I've read a lot of these papers, and I would say that this is healthcare in the sense of like well-constrained healthcare processes, but it's not a healthcare system. So even healthcare systems themselves really struggle with this concept of a digital twin. That's not to say that insights from manufacturing can't be useful. The province of Saskatchewan has been using lean healthcare, which of course came from manufacturing, the Toyota manufacturing system. And so lean healthcare has been applied in Saskatchewan and indeed is being applied in lots of places around the world. And it's been having some positive effect. So like I said, Saskatchewan's been doing this at least for 10 years. But in speaking with the stakeholder, I've found that what they said is basically that it had a lot of value in the components that weren't patient-facing. So things like human resources or supply chains. But on that clinical level of decision-making, it's a very it's a much more mixed bag. So I want to explore just a little bit about what the difference is between healthcare as a system versus some of the other domains where digital twins might make a lot more sense. There's a great paper online, a report online that kind of highlights some of the differences between a hospital and a manufacturing facility, and I'm borrowing some from those, and then I've added my own thoughts at the end as well. But from a healthcare system, we can understand that the patients coming into the hospital, the entities entering your discrete event process, they have a variability that you can't easily control. So in that sense, it's a little bit more like a mail sorting facility, and that has some important differences from a manufacturing. Healthcare is also a little bit more like a repair shop for cars, because you have this diagnostic process, right? So a patient comes in, you don't immediately know where they need to go in your process. You can't plan for that, so you have to put diagnostics in place to figure out where they need to go. Healthcare is also a little bit more like a university. And the important thing here is that you've got professional decisions being made by doctors, by nurses, clinical decisions, and there is no sort of algorithmic best practice. There are certainly best evidence and evidence-based medicine and all that, but it's the same as in a university where there's no best way to teach. So you've got professors or you've got doctors that are having to make expert clinical judgment in the context of their decision-making. And often that decision-making is in collaboration with the patient, right? So depending on the needs and the interests and the goals of the patient, that's going to impact the decisions of how the doctor treats them. This one I think is a really big one. Healthcare is different from some of these other domains because the active, high-intensity decisions that are being made are very interdisciplinary. So in this sense, it's like a scientific research facility where you've got different types of engineers and PhDs and researchers all collaborating together on some sort of central goal. In a hospital, you have a patient come in. They may have many different types of doctors that they've seen. They have a private care physician. They might have some specialist. It could be a surgeon, cardiologist, neurologist. And the kinds of care that's offered to them by each of those is going to be interacting with them. So there's a lot of sort of collective transdisciplinary work or multidisciplinary work that takes place in a hospital. Healthcare is also a little bit more like a court system because the entity that is of primary concern, the patient, is tied with their social networks and families. So you have patients coming to visit the hospital, and when the doctor is engaging with a patient for some sort of treatment plan, they're often engaging the family as well. And finally, I do think that maybe we've seen this a little bit more clearly since the pandemic. Healthcare systems offer some of the same services as religious organizations, or at least there's some similarities there, where you're dealing with patients, sometimes at very vulnerable situations, sometimes at end-of-life situations. You have highly emotionally charged interactions, and you can get emotional burnout in the staff, and I think we saw a lot of that in COVID. And this is a dynamic that I think is relatively unique to the healthcare system. I think we also recognize that digital twin approaches related to machine learning and AI, a lot of these things really depend on high-quality data. But in the healthcare system, there's many challenges present there that we're still learning how to navigate. Obviously, information privacy is one. That's not one that doesn't have there are solutions to that are being rolled out. It's taking time. But there are other ones that I think are a little bit more difficult to figure out. So the sort of level of accuracy of healthcare data is very different. A patient comes into the hospital, and the data that's being recorded is often being recorded manually. There are clinical judgments that are being taken. Somebody might come in and have their blood pressure measured, but that's just one moment in time. It's not continuous over a period of time. They might be asked pain levels, how much they could be asked about their activity level. And these things are, it's possible to extend it into smart devices and so on can get more of that information. But the accuracy, anyone who's worked with healthcare data will speak about the accuracy of that data being very, very different than maybe in a manufacturing pipeline. And I would finally say on the data question that the amount of data that could in principle be captured or that would be necessary to be able to reach a digital twin perspective, I don't know if that's very easy to say is available in a healthcare system. And I think really part of this whole thing, part of that, the data issue and the broader question of healthcare is that healthcare is just part of this. It's very hard to scope the healthcare system to be separate from the community around us. So we've got, one would be able to easily argue that over the lifespan of an individual, most of the health of that individual comes from their interactions outside of the healthcare system. So it's going to be the strength of their family connections, it's going to be the strength of the friends that they have, it's going to be their access to good food and exercise and a safe environment. And so a lot of these factors are going to be significant drivers of people's health, which is really essentially outside the scope of most healthcare systems and certainly hospital systems. So there's another framework that we're using in Saskatchewan, or that we've been learning about as I've been working with this Saskatchewan team, and it's called the Learning Health System. And I want to highlight just a couple parts here that I think are extremely relevant for our situation. The first one is that the Learning Health System recognizes that there's many important, high-impact decisions that are taking place across a wide spectrum. All the way down from very quick clinical judgments at an emergency department that nurses have to do in triaging patients, all the way up to provincial-wide or system-wide decisions on resource allocation and human resource allocation and so on. And so each of these types of decisions, they have different cycles of speed, right? And I think it's important to recognize that the healthcare system as a whole works with this sort of extreme diversity of different types of problems. And obviously that has to leverage different types of processes and policy and technology and people. The other part is that those decisions are being made, and again, this learning health system is a bit of a goal that we're moving towards, but the ideal in this learning health system is that those decisions are being made in this sort of cyclical relationship between knowledge, data, and performance. And so that you've got to leverage, obviously, different technologies and analytics to be able to convert that data into knowledge and then back into performance. But this is where I think that the concept we can borrow from the digital twin of having a virtual environment that you can use to study, I do think that's really valuable. So what we've been doing over the last few years is essentially bringing these two spaces together. This idea of a learning health system with this idea of being able to have a simulated or a synthetic environment. And so the framework that we're building together is essentially this integrated health system modeling approach. Excuse for the double L, and we're modeling Canadian clients, so sometimes that makes it into the presentation. But as you can see here, we've got this sort of a diagram, a cyclical diagram from the bottom that captures this multi-layer decision-making environment that we saw on the learning health system, but it connects them together, recognizing that decisions that happen at the patient level or at the unit level within a hospital are going to be impactful on the regional or even the provincial level. And then at the Ministry of Health level, where a lot of those decisions are being made, that's going to be obviously impacting all the way down. And we tie this all together with a systems modeling approach. So it's not necessarily one single model. In fact, you should be having many types of models for different types of problems. But the idea is you would be using these models to really facilitate the growth of our mental models, right? Because again, we have to leverage the capability of the staff that's making decisions, the doctors and the nurses that are making these active clinical decisions, the operations folks, and the policymakers as well. So the goal is to be able to show improvement in the speed of their mental model developing. Now, traditionally, what this does is you just have the loop on the right, where you've got your mental model, and then you, through quality improvement or implementation science or implementation research or other types of approaches, you act in the world in a certain way, and ideally there's some sort of feedback, and then you can learn more about your system and how to act in a new way. But the idea is that we can use, again, borrowing from this digital twin perspective, we can use simulation models to facilitate here. This is a snapshot of a model that was built within the Saskatchewan context of an emergency department. So you can use emergency department models, but as I'll talk about on the next couple slides, we've done a number of models beyond just that. And the idea is you want to build multiple models for many different contexts. So this was an older slide deck. It didn't quite get updated in time. I'm just going to jump to this one first. So about 10 years ago, I started on this particular model looking at emergency department flow. And so the goal here was, from the stakeholder, the goal was to improve the patient wait times, to reduce the wait times for an emergency department visit. When you come into the ED, to reduce the time until you're seen, and then you get transferred into the acute ward if you need it. And so you can, I don't know if you can see all the words here, but basically we're using, this was a system dynamics model, so I'm glad that there was a presenter earlier talking about SD. This is an SD model where we tried to capture essentially a single hospital. We've got the waiting area, the emergency department, the acute wards, and then these sort of post-acute in the community, long-term care, and so on. And so we wanted to capture that widespread. And this was an extremely valuable process to go through, and it essentially convinced the health authority to go full in on hiring a full-time modeler. System dynamics is really valuable for being able to mock up these things in a relatively quick amount of time. But the focus here was, again, mostly on the health system of a single hospital. Now, during the pandemic, obviously things changed in healthcare for a lot of folks, and so I got dragged in, or I joined the group that was looking at COVID modeling. And so we formed essentially what became known as the Advanced Analytics team, of which modeling was the core, but again, it was supported by many other data-driven approaches and evidence-based approaches. And the COVID modeling approach was really, there needed to be some capturing of the healthcare process, so there was some DES in the model, obviously, we needed to have that, but we really broke it up. I guess you can see in the picture on the top right there, that there's many different hospitals, many different communities, many different schools and workplaces all across the province, 1.2 million people. So we had an agent-based model that essentially looked at the COVID as it progressed through the community. So this is a model that essentially took as its core the dynamics outside of the healthcare system to generate estimates about what the demand might be, to help operational leaders come up with 1, 2, 3 week decisions around where they should be moving staffing, and to help policymakers come up with what we might be able to achieve with certain vaccination programs when those came out, or masking policies, or shutdown policies, or whatever at different stages of the pandemic. So if we take this COVID modeling, community-based modeling, and we combine it with this emergency flow modeling, or the single hospital model, we get where we're going now, which is basically system flow model more broadly. And so here we can see that we're trying to capture the complex interventions across many different parts of the system. And so this modeling process is underway. And we're trying to account not only for things within the hospital, so emergency department and acute care with the patient at the core. We also want to capture primary care. We want to capture different types of community care, so residential care in the community, home care, intermediate care. And we also want to make sure that we're leaving room for administrative decisions and so on. And so there's a lot of questions that we're beginning to ask now as we come out of the pandemic. For example, the surgical wait list. A lot of the surgeries were unable to happen during the pandemic, and now they want to be able to get through those surgeries. But as you increase the number of surgeries taking place, you're going to be increasing the demand on beds within the hospital and in the post-surgical care. So I think the modeling process through the pandemic really convinced some of the operational stakeholders that this modeling can be brought into the community, again, recognizing that there's no way that this COVID model that was built, or I would argue any COVID model, is going to be able to predict the number of COVID patients happening, given it depends on so many things that's not being measured. So we had this synthetic environment and this real environment, but we were unable to get to the point ever of being able to have something like a digital twin. So again, over the last few years, and we did present on this a couple years ago at the first online AnyLogic Conference. So I'm just going to summarize a couple parts here, but the video does exist, where we sort of highlighted 5 key components that we identified for this integrated health system modeling approach. The first one is the map. And obviously, for us, that's going to eventually be a model. But, and this is another benefit of lean healthcare, is a lot of the maps they build, so value stream maps and driver diagrams. These are all diagrams that are very useful to be able to bring into a model. But ultimately, we want a dynamic model, some sort of simulation model. And that model needs to be informed by data, which is wonderful. Everybody here is familiar with that process. But we need to be able to go outside of the data because of the limitations that I spoke of earlier. So we need to be able to go to broader sets of evidence. And again, this is some of the other driver diagrams and systems that we've done in the past. But we have to look at best practices. We have to look at publication research to see what other people are doing. So we need to be able to bring in a lot of that evidence. And then we need to be able to make sure that we're leveraging the domain expertise of the clinical and operational and decision-making experts and people, stakeholders that we're working with. So that contextual knowledge is really valuable and necessary for the model. And I think what we learned very quickly is that we all want to build useful models, right? We want to build useful models that get used. And that last part, making sure that the model get used, really relies on this concept of knowledge translation. And I want to make it very clear here that the knowledge translation we're talking about is fundamentally bidirectional, okay? Because we don't have a digital twin. We can't get to the point where we can put a model in front of a client and just give it to them to be able to run. We need to be able to make sure that the model that's being developed is being continually guided by the updated mental models of the people that we're working with. In the end, I think what I kind of want to communicate here is that healthcare, and certainly as a system rather than as individual parts, healthcare is very unique and is very complex, and is very important. I think everyone can imagine that. And the goal in healthcare, as we spoke about having many different kinds of models, is to come up with the right tool, the right model for the right type of question being asked in healthcare. And I think really this is all held together with embedded modeling teams. Right? And so this is what we're essentially trying to build in the Saskatchewan context, is a team where they can take on a lot of the work of the construction of the model and the formulation of the model and the scoping of the model, sort of as much as possible kind of on their own, so that it can be an embedded part of many parts of the decision. So that's my talk, and hopefully you have some good questions for me. Thank you.
Wonderful presentation. I know we've done a little bit of healthcare in our company as well too. One of the biggest questions I have is, as sort of like a leader of advanced analytics, how do you guys manage kind of the different industry standards when it comes to technical debt, when it comes to generating some of these models? So with some healthcare projects, it's a little bit more difficult to have just an automated solution, as kind of you were saying, where you just put it in front of the client. How do you kind of like manage that relationship once the initial MVP is deployed?
Yeah, so the question was, how do we manage the relationship once the model's been developed? How do we manage that relationship over time?
Yes, sir.
Yeah. So with the COVID model, there was this continuing demand for answers from the modeling team. So I think part of that is answered through having this embedded modeling team. And there's a broader health analytics team. And so the team that we're forming is part of that broader health analytics team. So we can leverage a lot of the relationships that health analytics team has with the community as well. But I do think it's important to have regular meetings based on the questions that the stakeholder has, right? So on the COVID question, it was very clear. What's going to happen next? What's going to happen next? But when we're dealing with system flow, at different stages of the season, at different stages, there's going to be different kinds of questions. So right now, it might be questions on surgical wait list, and in a month, it might be questions on the flu season, and a month after that, it might be questions on alternate level of care, patients in the hospital. So part of the modeling team's job is to try to get ahead of what those questions might be, to be prepared for when those questions are ready. Because a lot of the times in healthcare decision, I think this capacity that needs to be built within the decision makers to be able to know that a modeling ask can take anywhere from 3 days to 6 months. And we want to be ahead of the game with that. So there's a lot, that's where we're drawing on a lot of evidence and research. But we do have to leverage those relationships that we're building, and you kind of need like local heroes to be able to advocate, especially in the beginning.
Sounds good. Thank you so much.
Sure, thank you. Okay, thanks everybody.